Good evening, ladies and gentlemen. It's a huge honor for me. I'm like a living fossil in this gathering of young, energetic people. But I'm a living fossil. So thank you so much for inviting me, Venu and Mrinal. I think I've already learned so many things, and I've been amazed by the quality of the presentations. And as I look to the back of the room, I know that PMR is in good hands because I can see bright eyes and bushy-tailed young professionals who are eager to take on the challenge of rehab. Now, Raji took us through TBI at warp speed, because it was a huge chapter. From there, it's going to be a bit of a change. My topic is about constipation, rectosigmoid break, and delayed transit time. So it's the other end of the scale. We're going to talk slow. We're going to talk about things not happening. But it's an important topic in rehabilitation, and I hope that you'll enjoy this half an hour. Now, I'm going to try to keep you happy. Students at the back, if you will ask me even one question, that will make my day or my evening or my night. Okay? So what I'm hoping is that I can evoke some questions from you. So let's move on. Oops, let's try this. So this is my teacher. Her name was Mary Verghese. I'm going to leave this on for 5 seconds because I want you to look at her carefully and remember this picture so that wherever you see it, you'll recognize it. She is responsible for CMC Velo being what it is today. Being disabled herself, she designed a rehab institute that ticked all the boxes, and we owe everything that we are to her. Now, rehabilitation of neurogenic bowel involves managing and treating bowel dysfunction caused by nerve damage. Now, generally, we think of neurogenic bowel as only being a problem in patients with spinal cord injury, but this afternoon session is on many other neurological conditions like stroke and head injury and Parkinson's, and I can assure you that these neurogenic bowel problems do occur in them as well. But for purpose of discussion, we shall use a spinal cord injury model. But I hope that you will be able to extrapolate details from that model to all the other conditions as well. The primary goals of rehab are to establish regular means predictable and timely bowel movements, and prevent complications like constipation and fecal incontinence. And all this is aimed at trying to improve the patient's quality of life. Just a few minutes, let's look at what are the factors that contribute to stool continence. Now, if I can get the pointer, here it is. Here are the factors that help to contribute to fecal continence. I know that you already know all this. This anorectal angle is very important. That is maintained by this puborectalis sling. And for defecation, this angle has to be reduced. That means it has to be straightened out. And then defecation can occur. Here's the internal sphincter. That internal anal sphincter is responsible for 80–90% of continence. It's surrounded on the outside by the external anal sphincter. The internal anal sphincter can relax to allow a little bit of gas or fluid to go through so that the sensory part of the anal canal can actually decide whether or not it's appropriate for defecation to occur. The last bit is this rectum and sigmoid. The rectum has 3 semilunar mucosal folds which aid greatly in increasing the capacity of the rectum. So like the bladder, it needs to be compliant. As it gets filled, it needs to expand without an increase in pressure. The sigmoid also contributes to continence because there's this phenomenon called the rectosigmoid break, in which when the sigmoid contracts, it doesn't propel the feces forward. It actually holds it in place. So if you understand these factors which contribute to continence, it's going to be easier for us to deal with fecal incontinence and neurogenic bowel. So the two big groups of conditions in neurogenic bladder are the spastic and the flaccid. So injuries above the conus medullaris means that the lower motor neuron connection between the conus and the bowel is intact. So this results in a hyperreflexic pelvic muscle contraction and an inability to voluntarily relax the external anal sphincter. So that's what makes it difficult to evacuate, and this causes constipation and fecal retention. On the other hand, with injuries at or below the conus, the lower motor neuron or areflexic bowel occurs, and this leads to a slower transit, decreased sphincter tone, and constipation with frequent incontinence. So clinically, you can make out the difference by looking for the sacral reflexes and feeling and doing a rectal examination to check for the anal tone. Of course, I've put it down as black and white. In real life, there's a white gray area when there's a returning or recovering tone from an initial flaccid state. In the neurogenic bladder, there are lots of studies that have been done, and we've got lots more evidence for the reasons we make certain decisions. Unfortunately, for the bowel, only a few studies have been done. And so most of the recommendations that we follow are based on clinical experience and expert opinion. So this tells you that there's lots of scope for improved understanding and elucidation of the science of defecation. Now there are I thought I'll spend this 20 minutes with you to describe 10 key components of neurogenic bowel rehabilitation. Now, the first one, of course, is this thing called bowel training. You have to train the person's bowel to behave in the way it used to behave before the person had the injury or the pathology. So it's important to take a good history and find out if the person defecated daily, every other day, thrice a week, whatever. And what other things they did. Did they use the breakfast, the food at breakfast to get the gastrocolic reflex going? Some people do it in the evening when they come back from work and have a huge meal. But understanding the patient's previous experiences will go a long way to help you to train the patient adequately. So a typical routine would be to use the gastrocolic reflex from above, and sometimes, particularly when you're just beginning the training period, a chemical stimulant using some rectal suppository, glycerin suppository or dulcolac suppository. And if that does not produce the appropriate result, then a little digital stimulation with slow, gentle rotation of the finger for a few minutes will usually produce a result. Now, for patients who've got a partial lesion, abdominal massage, deep breathing, Valsalva maneuvers, forward leaning, all these can also help. It's important for patients to actually check with the finger that the evacuation has been complete before they leave the toilet, because otherwise they are more likely to have accidents. The second important feature in bowel rehabilitation is dietary modifications. High fiber diets, that's about 30 grams per day, are typically recommended to add bulk to stools and to promote regular bowel movements. You also know that you have to have adequate fluid intake to prevent constipation. Unfortunately, The fluid intake is often decided by whether the person has an indwelling catheter or is on intermittent catheterization. And so if they have an indwelling catheter, they can drink as much as they want. If if in some kind of a bladder training, or if they're doing intermittent catheterization, we tell them to limit their fluid intake to produce about 2 or 3 liters of urinary output each day. Now, medications. There's a long list of medications, but in general, there would be 3. You need stool softeners, you need laxatives, and in difficult situations, suppositories or enemas are used. It's important to remember that when you start the training, a fair amount of medication is often required. But once the person's pattern has been established, they can gradually be tapered and often stopped. Particularly, say, the stool softeners can be replaced by appropriate diet, high-fiber diets, and the laxatives are no longer required when the gastrocolic and the rectal stimulation has been trained so that they work adequately, etc. Now, I've made a little list of all the medications that are usually required. We don't have to go through the whole list, but just to remind you that there are 5 categories or more of medications. There's bulk-forming laxatives like methylcellulose or psyllium. There's docosate sodium, that's a surfactant. There's osmotic agents like lactulose as a suppository and as an oral fluid. There's stimulant laxatives, bisacodyl tablets and suppositories, and then the newer motility-enhancing drugs, lubiprostone, prucalopride, etc. I just wanted you to remember that the suppositories work quickly, within 15 minutes to an hour. All the other drugs take time, from half a day to 2 or 3 days sometimes. So if you remember that, if you need to produce a result immediately, you'd use a suppository. But if you're trying to change the hardness of the stool, you would do it much more slowly. Now, digital evacuation with the finger is required when it's a lower motor neuron kind of situation. And you have to remember that. The pelvic floor muscle training is useful in persons with an incomplete spinal cord injury. And walking, being active, rather than being in bed all day, all helps towards producing a good regular bowel evacuation. For persons who are tetraplegic, this has already been done in an earlier lecture. Transfers may require help, or flexibility of the trunk to reach the anal canal may be an issue, and aids and appliances may be required. Sometimes, again, initially, and as they get better, they are able to do it themselves. In incomplete lesions, biofeedback therapy is useful. Long ago, when we had lots more terrible obstetrics, people would come with grade 4 perineal tears after delivery, and I remember working with the surgeons trying to identify if there was any functional muscle using sphincter EMG, and then training them to contract the muscles using a piece of sponge with electrodes which would pick up the signals and get them to contract and relax. Electrical stimulation, we don't use that very much in our country. From what I can remember, the sacral anterior root stimulator is often most useful in helping a tetraplegic to evacuate his bowels at a predictable time. And some have used it to try to retrain incomplete cord lesions. Surgical options, particularly when paraplegics grow older, 30, 40 years after their injury, their colon doesn't behave in the way they expect it to or the way they were used to, and surgical options have been used, colostomy or ileostomy, to create a stoma that will allow for more predictable bowel evacuation. I just wanted to put in this bit about ongoing on-demand patient education and psychological support. Patients require advice from the team even after they go home, because suddenly for the first time they've gone for a wedding and things changed, and when they came back they find that their bowel has gone awry, and so then they ask for assistance. Sometimes they've had an infection and they had to take antibiotics, and that has thrown their bowel program out of gear. So telephone support system we found to be very useful. We used to have a sister, Bakyam, who was the ward sister in rehab, and she provided this really effectively, and patients appreciated that enormously because she was able to talk them through the problems they were facing and solve them for them. Now, despite these measures, complications of bowel dysfunction can occur in some patients, and here are a few of them. Constipation or stool impaction. Again, this can be a problem for multiple reasons. Sometimes patients go back home and then they are depressed and they're put on antidepressants, or they have pain and they're put on pain medication. Many of these can produce constipation, and they come back with terrible problems. It's important to take an X-ray, because by looking at how extensively the colon is loaded, you can assess how bad the constipation is. If it's only involving the sigmoid, then it's not so bad. If it's involving the sigmoid, transverse, ascending, descending, the entire colon, that really is going to take a few days to clear out. Another medication that affects the bowel profoundly are the anticholinergic medications we use for hyperreflexive or hyperactive detrusor. The newer anticholinergics are a little bit more specific than the older ones, but they're expensive. So most of the patients are still on the older anticholinergics, and it's a matter of titrating the dose so that the bladder capacity is adequate without producing too much of constipation. Now, both these are interrelated, because if there's a lot of constipation, then you'll require higher doses of anticholinergic medication to quieten the detrusor. So patience and working carefully with the diet, with the intermittent catheterization, with the medications is really, really important. Once they've come to you with constipation, it's important to use an enema or a bowel wash to completely clear the constipation before you can re-establish the bowel program. Some of the newer medications sometimes help, but most of them are really expensive and so are not available. But for patients who are repeatedly coming back with constipation, don't forget that there may be other pathology in the colon that you should look for. The other common complication is fecal incontinence, or bowel accidents as patients call them. This is not the bowel usually doesn't produce a life-threatening complication, but it's really a confidence-threatening complication that patients have to deal with. I remember one of my patients who was a teacher. She was T4 paraplegic, and she taught from a wheelchair. And because her continence was iffy, she always carried a bottle of water very prominently in the chair. And so sometimes if she had an accident, the students would all say, "Ma'am, your water bottle is leaking." And then she would say, "Oh, sorry." And then she'd go to the toilet and clean herself up. And so she told me that's the only way she could sort of continue to go to work. At that time, we didn't have as many drugs as we do for continence, and we were trying to keep her continent without a catheter, without an indwelling catheter. But she was able to cope with urinary incontinence. I find that fecal incontinence is much more threatening to people's confidence. I've had patients who've stopped going to work because they had one episode of fecal incontinence in their home, in their workplace, or while getting to their workplace, because you really feel demeaned and feel like a child. So it's really important to keep the patient on that program for at least a couple of months so they get completely confident about their fecal continence and their they know how they're going to handle an episode of bowel accident. Now, particularly with spastic patients, mass reflex is often a cause for this bowel incontinence. With patients who have a low motor neuron bowel, it's more likely to be impaction with spurious diarrhea. And the difficult thing about spurious diarrhea is they have diarrhea, they go to their local general practitioner who puts them on Imodium or gives them antibiotics, and of course that makes the diarrhea much worse because they actually have constipation and they have making that constipation worse. So it's important to explain to the patient about what spurious diarrhea is so that they take the appropriate measures and not make matters worse. Anal fissures are a common complication in persons with a neurogenic bowel, perhaps commoner in persons who've got a low motor neuron kind of bowel. But it happens, anal fissures are common in upper motor neuron lesions as well. In fact, for many years, it was, between the bladder and the bowel, these anal fissures are often the cause of autonomic dysreflexia. Mostly because everyone was very careful about the bladder. We knew it would cause a problem. They were careful about not getting constipated. But they don't have sensation, so they didn't realize they had a fissure in ano. So they would come in with hypertension and we would check, and sure enough they had a fissure in ano. So these can be treated very easily once you recognize them, but they have to be treated persistently because they can recur. So lignocaine gel will immediately reduce the autonomic storm. It will have to be used very judiciously, repeatedly through the whole day, because some patients have it only when they are actually doing a rectal evacuation. Others have it when they've been sitting for a long time because there's pressure on that area when they're sitting. Autonomic dysreflexia has been dealt with adequately, so I won't go into that. Now, hemorrhoids, because of the altered pressures in the anorectal area, venous varices are common, and hemorrhoids from stage 1 to stage 4 can occur. The treatment is the same as in persons who don't have a neurogenic bowel. The only thing is these often are a little more resistant to treat. If they don't have sensation, you can actually ban them yourself. But if they've got sensation, then you'll need to be much more careful. If they are prolapsed and infected and etc., then it would require surgery. During one of our big follow-up sessions, I remember we invited the gastroenterologist to come and do a study of about 100 patients who had come for the follow-up. And he was quite amazed at how infrequently this was occurring. We were, of course, horrified because we thought 5-10% having this was a large number, whereas the gastroenterologist wasn't surprised at all. And so if you can remember this and treat it adequately, it will not bother the patients. What frightens me often is because they can have significant bleeds and become anemic because they don't have pain sensation, and they sometimes are doing their toilet in the dark when they don't actually recognize that they are bleeding. Serious abdominal complications like cholecystitis, upper GI bleeds, pancreatitis, and appendicitis account for 10% of the deaths following spinal cord injury, especially in the first few months after injury. Now, I'm just mentioning that here because it is included in the abdominal complications, and it's not neurogenic bladder, but it is neurogenic GI problems because of the neurogenic etiology. And it's complicated because they don't have localizing sensation. So a C5 tetraplegic may have an appendicitis, and all that person may have is some fever and some headache, and perhaps later on autonomic dysreflexia. It's really important to examine the patient from head to toe every time they come, even with vague symptoms such as nausea, anorexia, or just not feeling right. And if you do that, then you won't miss it and you can save a life. Because sensory deficits really contribute to a delay in the diagnosis and treating treatment of these easily treatable conditions. So to conclude, the primary goals of managing neurogenic bowel is to establish a regular, predictable, timely bowel movement and to prevent complications. This is feasible by treating with simple remedies, and the effect on the improvement of a patient's quality of life is immense. Thank you very much. I hope there'll be some questions because there's lots of time.
Thank you so much, sir. It's always a good fortune to listen to you. Sir, actually, it was discussed about sacral nerve root stimulation and all.
Yes.
Is there any modality that can help in improving the sphincter control and further?
In re-innovating the sphincters? So sacral anterior root stimulation does produce evacuation of the bowel, and normally when the rectum contracts reflexly, the sphincter will relax and there'll be an evacuation. And you remember in sacral anterior root stimulators, the stimulation is in pulses, so that there's a contraction and relaxation of the muscle. So when the rectum is contracting and then it relaxes, at that point the sphincter will also relax. But direct re-innovation of the sphincter I've not heard of, but does anybody else know? Yeah, well, that's my information as well. There's no procedure.
Yes.
Thank you for asking that question. You saved the evening.
About some bisacodyl suppositories.
Yes.
Being in government setup in a rehab center, oftenly we came across the conditions like we used to prescribe bisacodyl suppository. Patient can't get it because of money and all. But we have government supply of bisacodyl tablets. Sir, what is your opinion on giving bisacodyl tablets perorally at the bedtime so that he can have bowel movements in the early morning?
Yeah, thank you for that question. It's a good question. So some of my patients also, we give them these fancy suppositories, and it's hot in Velo. We only have 3 seasons, hot, hotter, and hottest. So it becomes liquid and is not very effective or easy to apply. So, and they don't have fridges at home. So they usually end up by using either soap. They worked out that they can use soap as a lubricant, and some of them use castor oil. They have castor oil plants in their house. And initially I was aghast about the castor oil. Then I remember that when I was in Ofthal, I learned that we used to use castor oil for a lubricant in the eye. And then I thought, if the eye can be happy with castor oil, then the mucosa of the anorectal region should not be unhappy. So that's what they use. Many doctors are very, very unhappy about patients being on stimulant laxatives like Dalcolax or Bisacodyl long term. I haven't seen any literature that says that long-term usage of these is more likely to cause cancer or diverticulitis or any problem. I think maybe there was a problem in non-paralyzed persons, but in persons who have a neurogenic bowel, particularly if they have, I had one lady who had multiple discs, had a lower motor neuron paraparesis, but her bowel was really a problem. And for years, I've known her for 30 years, she's been using Dalcolax regularly. So I have lots of patients who are on Dalcolax tablets regularly. It's not an issue. The only thing is you have to get the dose correct for that person. Some people need 1 every day. Some people need 2 every day. Some people need 1 every other day. Because if you overdo the stimulation, you'll have diarrhea, and that doesn't help. So you want to give them an adequate dose so that it's working as a stool softener. It increases the colonic motility and also produces a little increased secretion of the mucosal cells. So there's a little lubrication in this. So I feel that the patients like it better than the low enemas that sometimes you have to use for patients who can't evacuate in any other way.
Thanks.
Sir, how to address spurious diarrhea?
I'm sorry?
How to address spurious diarrhea?
Spurious diarrhea. So spurious diarrhea, you have to produce more diarrhea. You have to get everything out. The spurious diarrhea is because there's impaction in the colon, and so if you can usually palpate and you can make out if it's the sigmoid or ascending or transverse or descending. And sometimes I find that if I take an X-ray and show it to the patient that your entire colon is loaded, that's why you're having diarrhea. The loaded colon is fermenting, and we give them lots of fiber, so there's lots of fiber sitting around there, and we now know that if the fiber sits there long enough, the bacteria are actually able to break it down, and produces a lot of fermentation. In fact, I used to happily tell my patients, you can have as much fiber as possible, you won't put on weight. But we actually now know that because of the prolonged colonic transit time, they are able to break down the fiber, and it's broken down into small sugars which can be absorbed, and it can actually cause increase their caloric intake. But be that as it may, the important thing to remember is that they've got this spurious diarrhea because they're impacted. So what you have to do is to evacuate the colon completely. Some of them will require extra doses of Dulcolax or bisacodyl tablets. Some will require a low enema. Some will require a bowel wash because a lot of feces will come out and the patient will think it's all done, but you can still palpate the colon as being full. And sometimes, when the patient is not convinced, I tell them, take another X-ray and then I'll show it to you. And then they take another X-ray and I show them that, you've only evacuated the sigmoid. The ascending transverse colon, all is full. So if you can evacuate the entire impacted feces from the colon, then you'll find it takes a few days for the colon to regain its function. It's as if it's been distended, like an over-distended balloon. It takes a few days for the colonic tone and the functions to be regained. So they have to go back to a shortened bowel retraining program. It's just like, when you have a person on intermittent catheterization, suddenly they get a urinary tract infection, it throws their bladder out of gear, they're leaking all the time, the capacity has reduced. So you have to treat the infection and then go back to a few days of sorting out the bladder, making sure that you give the increased dose of anticholinergic, which is anticholinergic that is required. You make sure that the bowel is empty. So similarly, it takes a few days for that to be sorted out. So if the patient is experienced, they will do it at home. Otherwise, I would admit them and make sure the bowel is completely cleared to stop this spurious diarrhea. Because if you don't stop it, they'll go back to the general practitioner who will again put them on antibiotics. So they're treating diarrhea, infective diarrhea, or they're treating some other form of diarrhea by giving them Imodium, Lomotil, whatever.
Sir, in case of a LMN bowel,
Yeah.
if I have, in case of a LMN bowel, I have ruled out constipation.
Yes.
Then can I go for Lomotil or Resicanutril?
I'll like to ask you a question. What would you do if you had diarrhea? If you had come to this conference and you had diarrhea, you'd surely take Lomotil. But if you were at home, you wouldn't take Lomotil. You'll just drink some extra water and use the loo a little bit more frequently. Every diarrhea is not like every chest pain is not a myocardial infarction. Every diarrhea is not something that you have to be very anxious about. If it's happening recurrently, that means the person needs to come back and get the bowel program retrained. But a one-off diarrhea is nothing to be afraid of. Most of the time it's because they have, they've gone for some function, they've had some foods that they don't like, that they're not used to rather. They like very much, but they're not used to. And they've overeaten, or there's some intolerance to some new spice that they've had, and that's thrown things out. And just a few days of being careful will sort it out.
One of the drugs you can give to clear out is sodium picosulfate. Again, it's not available in sachets here. If you can give 1 or 2 sachets, I call it the intestinal equivalent of dynamite. So they have explosive diarrhea for 1 or 2 days and that settles it.
No, lactulose now comes as plain lactulose and lactulose with sodium picosulfate. So you can choose that. The only trouble is if you just put them on the one with picosulfate, then you have too much of dynamite. And if you don't put the picosulfate, then you have too little. So it's a matter of telling them to have 1 spoon of this and every third day have another spoon of that. But it's amazing how well they work things out because they realize they know their own body and they're able to adjust their diet. Yeah, Henry?
The other interesting thing is in India, when you work with spinal cord injury rehab, I mean, I know after this class, you might wonder many people would have complained of bowel issues, but by and large, people don't complain to you of bowel issues, either bladder or pressure sore or something. But if you work in the West, it's just the opposite. I know somebody will pick up the mic as soon as I finish this because 90% of the complaint in your review patients will be bowel. Somehow it's probably the diet, I don't know, but they are very unsettled with the bowel and they do use a lot of molecules to maintain their bowel compared to our Indian cohort.
Yeah, I think that's right. That's because of their diet.
Yeah, so
Low in fiber, very often. Yeah.
So
So
all I can say is thank God for big mercies.